disclosures. I thought that I had absolutely no disclosures whatsoever because since I work at NIH, I'm not allowed to do anything with drug companies. But it turns out that I have a lot of disclosures imputed to me because I'm treasurer of the American Epilepsy Society, and the American Epilepsy Society gets support like booths and things like that from a whole bunch of drug companies. And I just found out about this. So many of you who think you have no disclosures may have disclosures that you don't know about. Okay, right. So this has already been alluded to, but there are obvious cognitive effects of epilepsy surgery. And actually, some of the most important points are that the risk is greater if you have higher baseline performance, and there may be an effect of resection size, and tissue pathology plays a role here in that if you don't have obvious pathology on the side of the resection, your risk is probably greater in part because you may have removed the wrong side. In any case, about half of patients with a left temporal lobectomy will experience verbal memory decline. Occasionally, patients get a little gain. Naming decline is about a third. With right temporal lobectomy, it's about a wash, but some patients do actually get a significant verbal memory decline, and some get a gain, and then obviously the reverse for visual memory decline. Now, what about the Wada test? So the Wada, as has been mentioned, has many limitations. Obviously, there are vagaries in the cerebral circulation, and you don't always know what you're doing. So this is a patient that we had with a persistent trigeminal artery who became unconscious because we anesthetized her brainstem when we injected the internal carotid. And testing time is very brief, okay? At best, you get hemispheric data. It's totally non-standardized. A lot of the effect depends upon what the radiologist feels like that day and how fast they're going to inject the amytal. So it's very difficult to do in children. It's not trivial to repeat, and up to 1% of patients can get permanent deficits. So it has limitations. Okay, does it predict outcome? So there are a number of studies, and I show you two examples of that, showing that there was, once you have preoperative memory assessment, which is extremely important, and once you have the structural MRI scan, and this isn't even taking into account functional MRI, doing a Wada does not add additional information that helps to predict outcome. Now, what about if patients fail the Wada test? So first of all, people do the Wada test over again. Very often the second time, the patient passes the Wada test. So here's a paper from Rathor et al. It may be from your institute, exactly. And so they had 116 patients who had Wadas. Nobody was denied surgery on the basis of the Wada, and they had a 12-item test and a series of cutoffs to decide if you passed or failed the Wada test. Nobody, even though they failed the Wada test, developed postoperative amnesia, and there seemed to be no effect of the Wada on seizure control, memory outcome, or quality of life. Okay. Now, what everybody has been worried about for many years is severe postoperative amnesia. And so, as of 2014 or so, there had been 10 to 12 cases reported in the last 50 years, 9 after dominant resection, but all of them had evidence of clear contralateral dysfunction or atypical language dominance before, independent of the Wada. So you could have predicted this without the Wada. And you have to ask yourself, how many patients have been incorrectly denied epilepsy surgery, which can be a life-saving procedure, because of a, quote, failed Wada, unquote. So I believe that the Wada is not helpful. And in fact, the world seems to believe that too. So here's a survey that was reported in Epilepsia some years ago, and you can see the change in people's opinions over time. So at the second Palm Desert Conference in 1993, 85% of centers were still performing a Wada in everybody. In 2008, only 12% performed a Wada on everybody, about a third very rarely. And in 2014, 85% of all the centers, and including 100% in Europe, thought the Wada was unnecessary. And we're also going to talk a little bit about grids. Grids was 50-50. And so we'll see where we are with that too. Okay, so Manjari alluded to this before. So we published a practice parameter on the use of functional MRI in 2017, and I'm going to go over some of the results of that. So both language and memory were included in this, and actually the two are very interlinked. And it turns out that you can predict verbal memory outcome using purely verbal performance tasks with functional MRI. So for language comparison with the Wada, there at the time that this was done, there were 13 class 1 or 2 studies, ranging in numbers of patients from 15 to 229. And you can see that various tasks were used, various kinds of baseline, and agreement with the Wada ranged from 70 to 100% of the patients in these studies. Okay, now what if there's disagreement? So the amount of data on that is still somewhat limited, but here's a study that was published by Janicek from Jeff Binder's group of 10 patients who had discordant Wada and fMRI results, and all had a left anterior temporal lobectomy, and it turned out that the fMRI was more accurate predicting the outcome in 7, the Wada in 2, and they were equivalent in 1. So theoretically, I suppose you could make an argument that you could do both, but it turns out that's not really necessary. Now, we'll get back to that in a moment. So for memory, there was also a significant correlation for fMRI and the Wada memory testing with both visual and verbal encoding tests. And clear left activation asymmetry during fMRI predicted verbal memory decline after a left temporal lobectomy. And if you created a model, okay, with the fMRI activation, the preoperative memory score, side of seizure onset, and also the structural MRI, you could get up to 90% or better prediction with those non-invasive imaging and neuropsychological tests. So the Wada did not add anything. Now, it's true, since nobody recently has had global amnesia, or at least has been reported to have global amnesia in the literature after a temporal lobectomy, we cannot say how well we predict it at this point. So that's a potential issue. Anyway, but it's better not to know because you'll only know if you have cases. Okay, so here's just a couple of examples. This is from Queen Square, showing, see, can I use my pointer here? So here is hippocampal encoding activity difference, and this is postoperative language change. So you can see that there's a very strong relationship between fMRI activity, and outcome. And here you have a study from Jeff Binder with a multivariate prediction model. So here you have, for example, the preoperative cognitive function, age at epilepsy onset. Here you add the fMRI laterality index, and if you add the Wada, you don't get any significant increase in predictive ability for any of the measures that they looked at. And here is just one more study showing exactly the same thing. 23 patients, 26 controls, a word encoding paradigm with out-of-scanner assessment, and then looking at the patients 4 months after surgery. Can I go back? Yeah, okay. And you can see the same kind of relationship between fMRI memory paradigm activation and outcome. Okay, now, so fMRI, along with several other pieces of information, can predict memory outcome as well or better than the Wada. Okay, fMRI can also provide explanatory information. 5 minutes? That's cool. fMRI can provide explanatory information on a number of other things. And here is one example. So why is there better functional recovery in children than adults after epilepsy surgery? And there are a number of studies which have shown that children are much more likely to recover to preoperative level. Okay, so this is a study that we did in comparing 142 about half and half children and adults with a set of verbal memory tasks, and it turned out that children activate both mesial temporal structures to a much better degree, a much higher degree than adults. So they do not have the same material-specific memory processing that gradually develops until you're 18 or maybe even later. The kids are engaging both mesial temporal lobes, so they have greater cognitive reserve, as shown by functional MRI. And that's something that you can't possibly do with the Wada test. Okay, now I just briefly want to talk about the potential for fMRI also to supplement, or if we want to be optimistic, even replace the need for subdurals. And this is language data. So this is a study we did of 17 patients who had grids along with fMRI, and then they had extraoperative language testing with the subdurals in addition to the fMRI studies, and then they had focal resections. And we co-registered here. We digitized the position of the grids, and we did the usual corrections for brain shift. And we then created regions of interest from the grids to correlate with the fMRI activation. And then we made resection masks. So here you can see the electrode stimulation site, the resection mask, the areas of fMRI activation. Here's the sort of gross resection. Here's a little area of activation near the resection. Okay, and then we looked at the ability of fMRI in comparison with grids to predict outcome. And it turned out that fMRI was as good as the grids in predicting whether patients would have a postoperative deficit or not. One of these people had perioperative infarct, several of them had basal temporal resections, but we could, at least in theory, have gone without doing the grids, although the number of patients here is small. Okay, so clearly fMRI has some problems. You can get disrupted bold signal if you have a mass, if you have an arteriovenous malformation. It's very important to make sure that patients are not in a post-ictal state, or have some cerebral circulatory disorder that you don't know about. Some people cannot comply with the test. A lot of people have difficulty hearing in the MRI, and it's always good to use several different paradigms. And if you're particularly interested in the hippocampus, there are only about 100 voxels in the hippocampus, and that can be tricky. Nevertheless, I contend that fMRI is at least as accurate as the Wada test for predicting postoperative language and memory deficits, and it may parallel direct cortical stimulation with subdural electrodes as a predictor of postoperative language deficits. We don't have a lot of memory data yet. So if you want to speculate, I think we're entering a new world in which we'll be able to do purely non-invasive pre-surgical evaluation. Thanks very much.